Hi, thank you. First, I'll have to congratulate or maybe commiserate with everybody sitting at the end of the long day and a half session. I congratulate you for your patience and willingness to sit to the end. It reminds me of the apocryphal story of somebody who was invited to give a talk in the wilds of North Dakota in the middle of the winter and made the decision actually that I would actually go there and traveled by plane, then by bus, and then by taxi, and I think by snowplow, and ended up coming to an auditorium in some institution. Walked into the auditorium, saw there was one other person sitting there, and debated if you should go ahead and give that talk. I mean, he made the effort and all that. I said, look, if one person came to hear me, I might as well give the talk. Gave his talk, showed his slides. At the end, he says, any questions? The person in the audience said, no questions. He said, well, can I ask you a question? She said, what in heaven's name are you doing here? He said, I'm the next lecturer. There are no lectures, no more talks after me, so be patient. I was asked to do something of a variation of what I usually do at the annual Academy of Breastfeeding Medicine. I do a research hit parade. I pick some 5 to 10 manuscripts that were published in the last period of time that I felt had some import in the sense that it interested me. 2, that it may have some import in terms of some impact on some decision-making in clinical management. The variation they asked me to do something in this setting is to find something comparable to that which has more public health implications, rather than specific management decisions in the care of a particular mother-infant dyad. I realized that I thought I only had 20 minutes or a half hour. They tell me I have 45 minutes, but I will. Rather than doing 10 hit parades or 5, I've chose actually 3, and I'm going to eliminate one of them and talk about 2 subjects, which I feel have great interest to me, but should interest everybody in this audience. I have nothing relevant to discuss in terms of financial relationships. I'm not intending to discuss any unapproved investigative use of commercial drugs. I am very biased. My mother told me that I was exclusively breastfed for 5.5 months. I don't know what the duration is. I would love to find out, but I missed that opportunity. We're going to talk about duration in a few minutes, so that's relevant. As I said, I want to summarize some recently published articles on breastfeeding, lactation, or human milk, review the results, and particularly focus on what I feel is the relevance to the issues of clinical care and public health policy. They're all human studies. Last 2 to 3 years they were published, and they're all from the English literature. There are other sources of information, but I think for this audience, I'm going to limit it to that. Okay. Now, the underlying theme in many of my presentations in general in the last few years when I talk about breastfeeding is I try to get away from the issue of nutrition, at least in an audience which is basically North America based. Many of you know that I do research in Ethiopia. Their nutrition, growth, stunting is the essence. That is not the key issue here. Or surely when I'm talking to an audience and I'm trying to talk to them the advantages of breastfeeding, nutrition is important, but it's the lesser of the hierarchy of things. We want to go beyond simple nutrition, at least. So that's sort of what is driving it. Obviously, I'm hinting with my cartoons here that we're talking about development. We're talking about ultimate health on an adult level. When we talk about research, we have to know what the source is. And I did a very simple thing. I went to PubMed. I put in 3 terms, breast milk, lactation, and breastfeeding, and I give you some idea in the last decade the number of articles have been published. I did not read all these articles. Actually, I probably surveyed pretty close to all of them in the last year or 2 in terms of their abstracts to know at least what's being published. But it gives you some idea of the wealth of information that's being generated in academic centers, in communities, in public health departments, and the like. It's an overwhelming amount, and it's beginning, I think, to define us, and I think correctly so, as an academic specialty. It's breastfeeding medicine. It's not lactation counseling, and I emphasize that. It's not simply nutrition. It's the essence of what is breast milk, what is the process of breastfeeding, which of course we know is not the same thing. The milk that comes out of the breast that's fed by the bottle, it's a whole different process with different implications, and surely it has implications well beyond the nutrition thing. What the mother's process of generating the milk, what we call the lactation process, and what those implications are for health of the mother per. Okay. Okay. I'm going to take two articles and I'm going to combine them, both published in the last few months. Cannabis use during the perinatal period in a state with legalized recreational and medical marijuana. The Association of Maternal Characteristics, Breastfeeding Patterns, and Neonatal Outcomes, an article from the Colorado group published in Journal of Pediatrics just a few months ago. And then an article which everybody's quoting because it gave some pharmacokinetic data, which we'll review very briefly, from the Tom Hale group, Transfer of Inhaled Cannabis in Human Breast Milk. Why is this a hot subject? I don't think I have to explain to you, but let's look a little bit at the numbers. 30 states as of the end of March. So something happened in the last month or two. I'm not up to date, but 30 states. Is it up to 31? Okay. And D.C. have legalized medical marijuana. 8 states and D.C. have legalized recreational cannabis, marijuana. I emphasize this. We have 8 states. The U.S. government has not changed its definition that marijuana is a Schedule I controlled substance. The phraseology that they use is no acceptable medical use, despite the fact that 30 states have legalized it for medical use, has a lack of accepted safety, okay, and a high potential for abuse. As a result, besides being the clash between the federal regulations and the state regulations, or actually legalizations, and I emphasize legalization, both medical and recreational. The problem is we ultimately want to know, we want more information to make some rational decisions. Because it has remained as a federal one, Schedule I, controlled substance, it is very difficult to do any research at all on use of marijuana. The federal government limits the source of the marijuana that may want to use. You can't say, I'll take it off the street, or I'll go down to the local store in Colorado and buy it, commercially and legally, and then do a study. It has to come from a federally authorized source under very strict regulations, and the bottom line is very, very little data is being generated today. And this clash is still going on. There is no indication that the federal government is about to change this. This absurdity exists and continues. Therefore, we only have anecdotal reports of how many pregnant women and how many women who are breastfeeding are indulging in any degree of regularity and quantity with their thing. The numbers thrown around are from 5 to 30%. I've recently seen people going on record saying, in their population and their clinic, and there are 30% of the mothers who are pregnant show up and have admitted to, self-admitted, so who knows how much it is. There is a general consensus, again, data very problematic, that where it is legally, recreational use is legal, and we now know it is in 8 states plus D.C., there is more routine use in pregnancy and during breastfeeding. How much more? Throw any number you want. But if it's X% in the next state, there isn't, it's X% plus. So I think the 5 to 30 is not an outlandish thing. It may be closer to the 5 to 10% than the 25 to 30, but we're talking about not something that is very rare. And to all indications, as more and more legalized recreational use is established, the numbers keep going up. We'll talk a little bit about why. I think it's clear, but I give you my viewpoint. As I said, we don't know a known percentage of breastfeeding mothers who indulge. And we surely don't know what, if any, cannabis is in donor milk. The requirements of Habana and the breast milk, we talk about breast milk, do not check for marijuana. Prolacta does, actually. We won't go into that. And if we're talking about something, it's bacterially safe, probably mostly viral safe. It's the pasteurization, the sterilization, all that, but not for substances. And if we are concerned, and we're using donor milk primarily, if not exclusively in most places, for our highest risk population, it's not a substitute for term babies by and large. That comes mostly from peer-to-peer relationships. You have to ask the question, what is going on here? Should we change our routines for screening, and what should we be screening for? in our donor milk. Give you some idea of the state, which is green. Green is, all the dark black is medically legal, okay, for medicinally. The green is for recreational use, and the gray means neither of the two. And again, not surprisingly, the West Coast and Southwest is one somewhat in the East, and there are pockets where it's neither this and neither that. Nothing very surprising here. It sort of matches some of the other maps we've seen with other indications. What do they do in Colorado? Nothing very complicated, nothing very fancy, but it was interesting. They have a system that's intact, been going on for a couple of years, which they call the Colorado Risk Assessment Monitoring System. They survey on a regular basis the mothers. This is the survey for the period of 2014 and 15. We're talking about 3 years ago population. And they got, the population N was 3,000, reasonably large number. I won't go into all the demographics, but it's well representing the sample of the mothers who delivered in Colorado during this time. And they really wanted an analysis of pregnancy outcome. This is a program that's been going on for years, so the methodology is set. It wasn't set up to measure. But they asked a simple question. Why? Because this is the time that recreational use was beginning to come in. I don't remember, to be honest, exactly when it became legal in Colorado, but it was during this period of time. So it does reflect probably a transitional phase. And they asked for self-report of prenatal cannabis use. Self-report. This is what people, so anybody knows this is probably the lowest estimate. But people willing to go on record. There was, no identification by name afterwards, but still it was somebody's self-report. They did all the appropriate corrections that you would want in a study like this when they were talking about other maternal outcomes and neonatal outcomes to make sure that you say all the babies are born premature, but they have other reasons. They did appropriate multiple regression analysis to correct maternal, medical, and social characteristics to try to isolate what, if anything, the use of cannabis in self-report group makes a difference. What they found, such as that, was a couple of interesting things, and I think we could extrapolate this or at least expand on this. Not an overwhelming number, people would say. The self-report prevalence was 5.7 cents in pregnancy and breastfeeding 5%, about the same. On the low end of this estimate, but there's a self-report for 3 to 4 years ago. Okay? It was increased in a very significant low birth weight, not prematurity, okay, and not to the degree of admissions to the NICU. But birth weight was significantly decreased. And I don't want to go over the calculations how we did this, but it was without a doubt. There was, in their conclusion, the use of this during pregnancy affected fetal growth rate. Okay? No long-term infant data. We have no idea on this group of mothers and their babies what happened to them. This is the simple piece of information. That is about as good as we have. It's a legitimate study, and it's from 2 months ago, Journal of Pediatrics, as up-to-date as can be. What would be the conclusion of this? It seems to have an impact on fetal growth. We don't know what the long-term implications are. We know that from other studies, that other things that impact on fetal growth, and you have an increased low birth weight independent of prematurity, all right, it does affect neurocognitive development. Not we're talking about a severity, but if you compare grade 1, sure, not Bailey's, but Bailey's a thing, but do your standard test of school-age children, you will find that you can correlate it with birth weight. And low birth weight is a negative factor in terms of, or it correlates, lower the birth weight, the lower the DQ, the developmental quotient, and you want to use it, the IQ. We're not talking about developing a population of severely damaged children, at least by extrapolating from our other data. But to say that it is an innocuous finding, it's hard to say that. But we clearly do not have any data on this population or any other population. And don't forget, we're talking about self-reported. We have no idea what levels. Okay? We don't know what the frequency of the use was. I mean, it gives you some idea of the quality of the data that we have here. The 5% prevalence is from 3 to 4 years ago. to everybody's assumption, conclusion, conjecture, whatever term you want, but everybody says, yes, 5% reflected a transitional period when recreational use was just coming in. From other indications, you have more in Colorado use, and then the next door states that they're not legalized recreational use. It's probably at least 10%, if not more. Speculation, but probably, I would say probably correct. But, you can't quote speculation. Interesting that the numbers didn't, people have said in the article, they say, well, the pregnancy rate was the same as the breastfeeding rate, and the indication that the mothers who are using cannabis during pregnancy, almost all of them continue during breastfeeding period. It's not two separate populations. Of course, we don't know the long-term effect. We'll talk a little bit about that when we go into the pharmacokinetics, but there is some data from some other papers that if you take a population, this is mostly European data, where they had mothers who were taking cannabis during pregnancy, began with intention to breastfeed, and compared them demographically and the like with this population who the only variable difference was that they were not taking cannabis. At the end of the 1 month, there were significant differences. The ones who were taking cannabis, the dropout by the end of 1 month was significantly different. There were less people persisting with breastfeeding beyond a month. It's not surprising because we know that cannabis does affect prolactin, a few other things. So is it a milk production or does it have some other association? We don't know. But it's not a good sign that you expect that the mother will stay on exclusive breastfeeding from the little data we have, even if she has the intention and the support, because the problem is not initiation. It's what happens when she continues and goes home. And if she was taking it during pregnancy, she'll probably be taking it during breastfeeding. And therefore, she will not there'll be a tremendous drop-off in terms of the breastfeeding as they get to the end of the first month. What the long-term effects is, we don't know. All right, let's just quickly go through Thomas Hale's group paper. There's nothing very surprising here except it's hard data, some pharmacokinetics. Background is we have incomplete data. It's very hard to know what the mechanics are. I'm sure I don't have to tell you people. I don't ask individually how much you know about this. But it makes a difference from cigarette to cigarette, as they say. What your source is. All cannabis is not the same. Somebody who self-reports, you can't compare to somebody else. It's not the same level. There's quality, as they say. Surely if you go to the stores in Colorado, try it one day and see what they offer you, the variety, the intensity, the strength, and all that. It's real. Okay. So they went to a very simple study. They wanted to do that. And some of the logistics is they couldn't take mothers who were not taking it and give it cannabis because that would violate, surely they would have problems getting through their, as we say in Helsinki, I don't know, the IRB, right? So they found a group of mothers who claimed that they were regular users during pregnancy. Okay? They delivered, and they were willing to stop for at least 24 hours. They rely on that, so they could get baseline in the mothers, and then gave him a measured amount to smoke. The measure that they had, a source, they measured the amount of cannabis, or the active agency, and then follow from a single smoke. How much gets into breast milk? And they went to the mothers to continue breast milk for only 4 hours. So we're talking about the immediate effect. This is the big like I said, not 24 hours, not repeated use, not varying doses. It's a single dose schedule. But this paper is being quoted all around. I'm sure you've heard, anybody in this has heard this. Okay. And what they find, that roughly 2.5% of the maternal dose came from a single smoking. Now, that sounds like a small amount. It's not a tremendous amount. And generally speaking, if we talk about drug use during pregnancy, it's one thing, but drug use during breastfeeding, and we know that the baby's getting less than 10%, but surely 2.5% of the maternal dose calculated per weight, however you calculate it, you generally think that's a pretty safe thing to be exposed. The trouble with this is that there was one quantity they knew, and we know that out in the field there's different quantities and intensities, okay? It's a single dose, and we know that it tends to accumulate, okay? It has fat solubility and slow neonatal secretion, I should say, or excretion, and therefore there's no doubt the repeated smoking that you would have some lead to accumulation, but we don't have the numbers. So to extrapolate from a single dose is careful, but And 2.5% is much more than in the literature. Most of the literature talks about less than 1%, and it's not a big problem. It's based on 1 and 2 isolated studies and a couple of patients done in Europe. Right? So the first thing I would say is don't go around assuming that it's so low that you don't have to worry about it. It's surely more than 1%, and 2.5% on a repeated basis, if the mother smokes more than once a day and continues to breastfeed, it's going to accumulate. I can't give you more numbers than that, but don't dismiss 2.5% as an innocuous amount. We know now that we know from other studies it decreases oxytocin, so you have interference potentially with the letdown reflex. It reduces prolactin. How much does that affect the milk production? But we have a basis to understand that the mother who persists in smoking on a daily basis, and that may be 1 cigarette instead of a glass of wine before she goes to sleep, how that potentially will interfere with her milk production and her success in breastfeeding, and therefore it is not surprising at all, that at the end of the month, the mothers who had intention to breastfeed and all the good care that they would get in a baby-friendly hospital, but went home and continue, at the end of the month, they are continuing breastfeeding at a much lower rate than other mothers. It affects dopamine. Now, what we're beginning to learn about the whole question of neurotransmitters and metabolism and brain development is a real issue. We tend to, you and I worry about our neurotransmitters, and we may take drugs to interfere because of a need for psychotropic drugs, whatever the reason is. That's to calm us down, to make us feel better, whatever it is. It's reversible. It doesn't do anything there. Neurotransmitters as a group are critical for brain development. There's a paper just published last week or two about the use of SSRIs in pregnancy. And they follow them with interesting technique of MRI techniques, without going to there, to show that the brain structure is different in the babies who clinically look perfectly fine. But the fetus was exposed to SSRIs of a standard dose used in mothers during pregnancy, that affects brain development. Neural migration, to a certain extent, and synaptic development is dependent on neurotransmitters during that. It's not for you and me. We're beyond that critical point. After the age of 3, we pretty much had all our synapses. We just pruned the ones But the critical period of the fetus, and surely for the first year of life, surely during the period of the breastfeeding, interfering with neurotransmitters has potential long-term implications, which you will not see at all in any clinical examination that we're doing nowadays. That may show up when the kid gets to school age or later. Behavioral too. So I feel less than fully comfortable about dismissing the use of marijuana that affects surely the fetus, but here for this subject, for this conversation, that affects our babies through the breast milk. I can't say it's innocuous. Therefore, what do you do? Now comes the public health question. I have states going on legalizing recreational use. Even in the states where it's medicinal, legal, we know it gets into this circulation for the reasons we all know about. If we legalize something for recreational use, we are legitimating its use. And we don't say it's limited to people who are not pregnant or people who are not breastfeeding. We don't say that. At least we don't publicly say that. What should be the public health recommendation? Well, you heard from ACOG yesterday. They say, what? You shouldn't breastfeed. It's a categorical. Most of the people in the illicit drug specialty, various clinics, if there's any half concern that the mother may be taking, let alone she admits that, cannabis in any shape or form, any degree of frequency, absolutely breastfeeding is contraindicated. The Academy of Breastfeeding Medicine took a different tact. If you read the last protocol, essentially comes without even some of this data saying, we don't recommend it. It's not a good idea. But if the reality is that after our advice for the mother to cut it out or to reduce it as much as possible, she's still going to go on. And we know that the alternative is not to stop breastfeeding. Still, the trade-off of breastfeeding for these babies outweighs the theoretical risk of continuing with breastfeeding, with smoking without this. That's the Academy. The Academy of Breastfeeding is an outlier on this. I don't know if the Academy of Pediatrics section has taken a stand on this. In draft. So you'll tell me, well, not tell us what they want to say. I throw this out not to be totally facetious. Should there be a warning labeling on the commercial products, like in alcohol and cigarettes, that it's detrimental? We don't stop mothers from drinking. We just tell them that it's a risk during pregnancy, and even it may have an effect during breastfeeding. So it's smoking and alcohol. Why should cannabis, that's legal and commercially, shouldn't have a label? Who in the government makes that decision? Now, they don't even want to discuss that while they're still defining this as a Schedule I drug. How can I talk about labeling something which I'm telling you shouldn't be using? And that's part of the end result of this. The right hand doesn't know the left hand. The federal government is going off and continues to see it in its extreme, and therefore isn't willing to acknowledge the reality of what is going on in the field. And if it's 8 states now, it'll be 10 states in a couple of months, and 30 states, and the medicinal is essentially almost like recreational use. More and more that's used, and it's out there in the market, just use however people want to use it. And they refuse, therefore, to label this. So this is the public health implications, which the people are responsible are not confronting, because they're hung up on, for whatever their reasons, to continue to define it as a Schedule I. And should, in some ways, we insist that milk banks test for this. I would not be happy, knowing what I know now, and I still wear the hat occasionally of being head of a NICU and worrying about my premature babies, to feed donor milk that I know or presume that there may well be real amounts of cannabis in this to a preterm baby, when I'm worried about his neurodevelopment for 5,000 other reasons. At least I should know. Let me make that rational decision. So they tell me I have to pasteurize milk. So I don't want to give anything that's contaminated bacteria-wise. Why shouldn't I be labeling there, or at least require the breast milk that's being delivered to preterm babies? At least I should know it's there. That's a public health issue. Okay, it's not a decision on treating one mother and infant and what to do. Okay, that's this subject. All right, I want to talk about kangaroo care, but I won't, because that's going to take too much time. I want to go into what we're concerned about in this country. Obesity epidemic. Okay, we're talking about from the last decade, a little bit more, from 1999, 2000 to this year. The blue is overweight, the orange here is obesity. So we've gone from 28 up to 35%. We've gone from an overweight obesity, we're talking about obesity, the childhood obesity we're talking about, from 17% to 26%. This is the real nutritional epidemic in this country. It's not the work I do in Ethiopia worry about stunting, where 30 to 40% of the children don't grow, and therefore they have irreversible brain damage. Okay, now, this you've seen a couple of times today, but I want to highlight it. Not so much what the current rates are, which, just to remind you, the current rates of 6 months is 51%. At 1 year of any breastfeeding, well, it has to be any breastfeeding, because after 6 months, we all agree when you give complementary food, is 30%. Okay? 30%, that's the current rate. What bothers me a little bit is the targets. We're aspiring to succeed that in 2020, in 2 years, we'll get to what? A third of the babies will still be feeding. And that's going to be considered a spectacular success. What are we talking about? If we believe that it really has value beyond nutrition of the first 6 months, or the infection thing, or the SIDS impact, or the neck for premature babies, which is all real, but if we talk value beyond continuing, why do we at least say a target of 34%? It's almost insulting that that's all we expect. We have a reality, we're far from it, but at least give me a target. I want to, no less than the 80% of the initiation, or 70%, whatever number you want to use, if is there any value to it. And if there's no value, what do I need the target for? What do I need, why do I have to worry what's happening in the year? If there's value, let's go for it. If there's no value, let's not go for it. Let's not drive a mother's crazy. We do enough demanding of them. Somebody talked about, fed is best. They're reacting to something. I don't agree how they reacted, but it's not out of the vacuum that they're reacting. So why make demands on them, but it doesn't make a difference? This again, this is the report, the CDC breastfeeding report. And if you're looking at the how many on the initiation, the West Coast and the Northeast are doing very well in initiation. If you're looking at any breastfeeding in 6 months, there are a few states left on the West Coast and the Northeast. It's not only that the numbers are low, the majority, by far, of the states don't even come close and will not come close to these low targets, which is, to me, reinforces almost the absurdity of these targets. I know what I'm saying here is sacrilegious, but I really think it's ridiculous. Either you believe that it is, set our goals and sights much higher. If they're not of any value, then don't drive ourselves nuts. I'm not saying you should stop breastfeeding, but don't drive the system crazy with a public health request. Now, what does the Academy of Pediatrics say? Just having written the statement, I should know what it says. About 6 months of exclusive and continuing for 1 year or longer is mutually desired. Basically, it's a license for the 1 year. And we don't really, but it essentially says, who cares what happens afterwards? You want to go ahead, it's fine, it's no harm to it. But it's a very personal, and there are very few people, for all the reasons we know. WHO doesn't say about 6 months, it says 6 months. They don't want to put that word in. And they talk about 2 years, and in their various things, they would encourage even beyond the 2 years. The 2 years is sort of the absolute recommendation. Again, from the perspective of somebody who works in the sub-Saharan Africa, that is the appropriate recommendation. It is relevant in terms of nutrition. Without continuing breastfeeding for 2 years and having the appropriate complementary food, you cannot meet the nutritional needs of the population in sub-Saharan Africa. You can't do it with one or the other, you need both. Is there any nutritional value in the developed world? There's no data at all that you have to go beyond the year. There's very little data at all that you have to go beyond the year. But there's increasing data that there is. And that's this paper. Duration of breastfeeding, but not timing, of solid food reduces risk of overweight. Very nice study that was just published in the International Journal of Environmental Research. It was basically they wanted to separate out if the issue of duration of breastfeeding or the timing of introducing of solid food. Because many people have made the case when we introduce complementary foods, we change the mix and we change the caloric intake and how much more protein, fat, and all the mix, and that is a major contributor to ultimate obesity. So, but some people say, no, it isn't. So they try to separate this out. It's not an easy study to do. They follow 900 children prospectively, basically all term in terms of their gestational age. 93% of them were over 2,500 grams. I would have been happy if they took out the babies below that 7%, but it didn't affect the statistical analysis too much. They did all the appropriate and very sophisticated statistical analyses to correct for what you have to correct for. And what was the data is? 2 major factors affected obesity at age 2 to 3. We're talking childhood obesity, okay? At 3, that's big time stuff, okay? Maternal BMI. Fat mothers have fat babies. Is it genetic? Is it environmental? Is it feeding pattern? But that's real, okay? And losing the BMI over 30, you could see how much the adjusted odds ratio was, and the p-value was off the chart, okay? There's no doubt that the maternal nutritional weight status is a variable. It may be the most strongest of all because it encompasses a variety of things, both the genetic endowment, the feeding pattern, cultural things. You could add a long list, but it's the best marker. And therefore, that should be a trigger for those of us who worry about the babies if we see a mother who surely her BMI is over 30, even over 25 to 29, getting closer to that, to focus on the feeding patterns here. What about duration in solid food? If the baby continues to get breast milk beyond a year, that's when we affected, in a positive way, reduce the rate of obesity. All right, it didn't make a difference if the baby fed for a half a year, and probably not close to a year. There's half a year to a year, so they mix the numbers. But the group of babies who continue breastfeeding after a year, they're getting all their complementary food. They didn't go into that much detail of the diet. Had a dramatic decrease in of being overweight, obese. That's not 24 to 36 weeks. That's a mistake. It's 24 to 36 months, which is between age 2 and 3. It's not weeks. Please correct that. The age when they introduced solid food did not have any statistical correlation, okay? So the conclusion is that as we see with cognitive development, and at least the newer data that we have, that if you get up to a year, how much more than a year, but surely continue to breastfeed for a full year as opposed to 6 months, you will have a significant increase in your measurable developmental quotient. Can't use the word IQ at a year, but surely it affects neurodevelopment. But it has to get to the year. There is that data is. To protect against overweight and obesity, you need that. So I think there's increasing information demonstrate that there is value at least for a year. If we continue to, or 2 years like the WHO, we don't have that data. That's not studied, and it'd be hard to find a population in this country to study. But surely I could go back now and accept the concept that, as the AAP says, hopefully we'll continue to say in some form or another, that we should feed at least for a year, and I think I have some scientific, medical evidence to justify that, and not take what I almost implied, that if there's no evidence, stop driving the mothers nuts and let them do what they want to do after 6 months. So the little cognitive data that we have now, and now the obesity, overweight obesity data, does justify absolutely continuing to recommend, in my mind, a full year of breastfeeding, surely beginning complementary food at the 6-month period, et cetera, et cetera. I can't say anything, what is the value beyond the year. So, but the conclusion is that at least for 1 year, half likely to be overweight as opposed to those breastfeeding less than 17 weeks. This is corrected for all the appropriate things. And apparently in some analysis, and I don't want to go into detail, it wasn't, it's not a, as I say, up to 12 months, it doesn't make a difference. And one day over 12 months, you start reducing it. As you approach the 12-month period, and it's not clear when is that critical period. It's after 6, 7, or 8 months. But as you approach it, for every week that you continue breastfeeding, you will have a certain percentage reduction of the risk of overweight and obesity. But the bottom line is, yes, continue to recommend. If that's true, please change your targets. Why have a target of 34% of something that I'm going to reduce a major medical epidemic? If overweight obesity and all its implications is such a horrible thing, and it is for children, so why am I saying that all I'm trying to do in the next couple of years to get to a third of the mothers? I want 100% of the mothers. I know I won't get there, but don't recommend something that I write off 2/3 of the population. There's something wrong here in how the public health reacts and builds its recommendations, I think. What's the mechanism here? And I just throw this out. There's a whole discussion into itself. We know that breast milk is different than formula. I don't have to tell you that. One of the things, and an interesting thing, is that the excessive protein that comes almost with all formulas compared to the amount of protein, I'm not talking about the quality of the protein that's in breast milk, clearly is stimulating, growth factors, insulin growth factor, particularly growth factor 2. So we know there are stimuluses to excessive growth, and if it's stimulated by IGF, it's excessive growth, including adiposity. It's not just tall and muscular. It's fat children. We know breast milk has a variety of hormones which essentially regulate diet, metabolism, and appetite. And this feeds into the fact that when look at the last one, the babies who are going to the breast regulate the amount that they take much better. They stop when they want. You don't have the mother continue in. And there's at least one paper to show that whatever little difference there was in growth rates, there was some data. If you feed pump milk in a bottle, you don't have that advantage because the babies never learn to self-regulate. So again, it's again the question of value of breastfeeding as opposed to feeding of breast milk. This needs to be sorted out. I'm even again the question of gut microbiota. We know different rates of different patterns of absorption, and therefore, although that's a question because most of the breast milk affected gut microbiota is set in the first few months, and relatively little has changed what you feed after 6 months. It's the critical period of setting the microbiota and its effect on gut metabolism and absorption is really an issue and a phenomenon of the first 6 months of life. So people talk about this, how to add this up, which is the more critical factor, which is the more important factor. Stay tuned. Invite me next year, maybe we'll have more information. I said a few times, I'll just complete, breastfeeding goals need to be reevaluated if we want to impact on obesity epidemic. Stop this nonsense of ridiculously low targets. That's a message that it's not that important. If my target of success is 1/3, I'm not serious about it. Is duration protective effect there? Okay. So the question of pump milk versus non-pump milk, breastfeeding. remains to be sorted out. And the lessons I think we all know, and I just have to catch a train in a few minutes. I'll finish on time. Maybe there's some question. There are societal changes, be it legalization of recreational drug that along comes with that some medical scientific knowledge that we didn't have, or surely implications. And therefore, we have to consider revising what are seemingly logical and appropriate public health practices and regulations and pronouncements, but were set at a different time, relatively recently, but a different body of knowledge existed or didn't exist. And we should be willing to have the flexibility in the system to adjust to the realities. That's my message for today. And as I say, let me go down. The future is all in your hands. Make your decisions. And I thank you very much. You see, I'm still a neonatologist.
Questions for you or any of the questions from the previous. Can you go to the microphone to ask questions? Bill is the author for the obesity study.
Yeah, Bell. International Journal of Environmental Research and Public Health. It's a March issue.
I just had one question out there. I wondered, have we done the similar research for neurodevelopment with nicotine? I know we banned it, and we tell moms, but have we done the comparatives? Because I know those babies come out with smaller heads, and I'm wondering if we can also get them to do that work if it hasn't been. I hadn't looked at the literature.
I'm not happy what they say, so I won't say it in their name, so to say. But people say, well, it's better to smoke your, marijuana than to smoke your cigarette. First of all, we shouldn't make that an issue. They're separate issues, they're separate thing. But it's not. Shouldn't be seen as a trade-off. I have less concern of the glass of red wine for the mother who's nursing. I don't think that I'm comfortable with. Not going to get into alcohol during pregnancy, but alcohol during breastfeeding, a glass of red wine before you go to sleep, perfectly comfortable with, as opposed to, surely, cigarettes is a big issue, surely in terms of SIDS. If the mother's smoking or the person sleeping on the other side of the bed is sleeping, those are the real issues maybe with smoking, let alone its effect on even secondary smoke on the lung development of the child. Not even to talk about neurodevelopment.